Good morning. Let's try that again. Good morning. I'm not a morning person, so I've got to help myself up more than anything. Great to be here. Such an honor to be here with you all, and just an honor to be asked to be our keynote speaker today. And I want to clarify that I'm using the title elder here with the utmost of respect, not elderly. In my collectivistic culture, I'm a Vietnamese American. Elder is given basically the utmost title and compassion and resilience and title of utmost respect. In my community, if you're an elder, you can say and do whatever you want. You don't get to ask, others don't get to ask you questions. So when I say about caring for our elder HIV community, I really mean that with the most respect, in the sense that when our elder HIV community members tell us what they need and what it is that they could benefit from, and what are the things that help them continue to be resilient and proud, we need to listen. And so when I use elder, I use it with this compassion and recognition that there's a lot of resilience and power here. So the usual disclosures, I don't have any particular disclosures, and the disclaimers were already shared. So here's our bit of our 40-minute roadmap. I'm going to use the concept of intersectionality to really frame, and systems of influence as our framework for our talk today. When we talk about intersectionality, we're talking about HIV status, we're talking about aging, we're talking about mental health concerns. I'm a psychologist by trade, so could talk about mental health concerns all day. We will then review common concerns at the intersections of HIV, aging, and mental health, as I mentioned. Really want to work to amplify client voices in sharing perspectives of aging and HIV. Throughout my presentation today, I have various quotes that my own clients and patients have told me. I worked with the Veterans Administration for 14 years, and one thing I learned about veterans is they don't hold back, so they'll tell you anything. So I have their quotes with their permission embedded throughout the presentation. And then lastly, I want to inspire systemic, strategic, culturally affirming, and individual and collectivistic strategies for meeting the needs for our HIV communities. I know that's a bit ambitious, but I know we can do it. Happy Pride Day again, or Happy Pride Month, I'm sorry. Would ask you all to take a moment and think about something that you feel pride in or feel proud of. And so I'm going to actually ask for a little bit of audience participation. So if you take a few seconds and think about what's something that, as you sit here today, June 5th in the morning, what's something that really overwhelms you and makes you think about when you think about pride and being proud. And when I say it out loud, the sentence I feel pride in, I'm going to ask you to say it out loud. Sound good?
Yeah.
Okay. So ready? I feel pride in. Let's try that again. I feel pride in. Okay, so hopefully we'll continue to get louder as the day progresses. I also want to acknowledge that there's a lot of awareness days and celebrations, not just today and in the future. Actually, when I realized that it was HIV Long-Term Survivors Day today, I thought to myself, what a coincidence. Here's the symposium on long-term survivors and aging and HIV, but I imagine that was intentional. So good job, planning committee. We also had LGBT Elders Day a couple weeks ago. We have testing days coming up. If you go to this web link here that I've included in this slide, there are a ton of testing days and a ton of awareness days in consideration for the intersections of HIV, communities of color, sexual identity, LGBTQ+ communities, and so on and so forth. I'm going to frame our talk around intersectionalities. Hopefully, folks have heard the term intersectionality. It was coined by Kimberly Crenshaw in early 90s. Intersectionality is used to reference how systems of oppression and identities overlap, intersect. How we can apply that to today's talk is that when we think about the intersections of HIV and aging and mental health, we might say that someone who has an HIV positive status has unique experiences when we look at their experiences compared to their HIV negative counterparts. Now, when we add this identity factor of aging, folks with HIV who have been long-term survivors perhaps have had HIV for 30 years. That's a different experience from someone who may be just newly diagnosed. And then when we add this experience of mental health concerns, whether depression, experiences of trauma, experiences of isolation, those are unique experiences that intersect and overlap. And that's how we might think of when we think of intersectionality. And all of these have systems of influence. I have these two diagrams here that I particularly like and use pretty often, but we might think of HIV and age and mental health concerns in this kind of internal dimension here. And then when you go outside that inner sphere, you have community dimensions. Where do they live? What are the factors in terms of their access to resources? What is their healthcare like? Is their healthcare integrated to where they're able to access it easily? When we go beyond that, we think about other forces that are happening in our communities, in our lives, the influence of education and religion, the influence of where we grew up. And then, of course, international events and local events that impact a person. So we'll use this as a way to talk about intersectionality and the ways in which HIV persons may experience these unique factors. And so in sharing that, I want to also share that I have an intersectional lens that I'm trying to come from as well based on my own experiences. I promise this is not meant to be an eHarmony or Mesh.com profile. But really this is just to say that I have my own intersectional identities, and these identities form the lens in which I see the world. And as I give this talk, I want to recognize and own that these perspectives are shaped by my experiences. So as a 40-year-old, I'm a Vietnamese American man. I'm partnered, I'm cisgender, identify as gay or queer. I was born in Oklahoma. Anyone else from Oklahoma in here? I didn't think so. Okay, I moved to California 15 years ago and definitely consider myself a Californian at this time. In juncture, I'm a child of immigrants, and I think that's important to me because I was raised in a very multi-generational household. This is a picture here of about half of my family members. And I grew up with every single one of these people that were in this picture here. So there's about 25 of us or 30 of us in this photo. And at one point, my grandparents, who had 7 children and 25 grandchildren, who raised all of us in 2 homes. I grew up with aunts and uncles and cousins all the time. So my early shaping and my early adolescence was really shaped by what it meant to be in a collectivistic household, in a multi-generational household. And I really emphasize that not only because it helps to shape who I am, but it's how I see the world. And I think it's how we can care for our HIV elders in collectivistic ways, in ways that are culturally affirming, in ways that help them feel seen and valued, in ways that we don't question what they need because we recognize that they're the power of their own stories. I'm also a psychologist and a professor. And then to identify the intersectional communities, HIV communities that I've worked with, I worked with various communities in Oklahoma City. I was trained in Dallas and the Fort Worth, Texas area. I live in the San Francisco Bay Area. I've also used to run a nonprofit based out of Guyana, South America. So when I talk about the quotes that come from my HIV clients and folks that I've worked with and come to love, this is the context that I'm working from, including their intersectional identities as it relates to age, veteran status, race, ethnicity, socioeconomic status, cultural identities, so on and so forth. I want to share a little bit about someone I admire, Chimamanda Ngozi Adichie, who talks about the danger of a single story. I won't show the video of her TED Talk today, but she really talks about how it can be really full of bias and dangerous when we zone in on one singular story of an individual. So this is going into intersectionality, where she talks about if you zone in on a particular identity piece and then make that all of them and all of who they are, you're missing the larger piece and larger story of this. So there's a danger here in identifying and perceiving people based on one identity, which can contribute to our experience of stereotypes of them. So would definitely recommend folks viewing this video entitled The Danger of a Single Story. With that in mind, I want you to think about and take a few seconds to think about what is one of your singular stories. As you are here today thinking about our discussion on HIV status and the intersections of age and mental health concerns, what is one of your singular stories that perhaps you zone in on in a way that doesn't actually give our folks the larger narrative of their lives? What is your singular story about older folks? What is one of your singular stories about folks with HIV? What is your singular stories about folks who have mental health concerns? My question to you is also, where did this story come from? Who told you of these stories? Who told you these narratives? Where might these narratives have come from in a way that doesn't present the full picture? Also, what maintains the story? What are the things happening in our world today that continues to reinforce these narratives in ways that are not complete? And lastly, what other stories better serve our clients and better serve our communities? Okay, I'll go through the next few slides relatively quickly because it seems like some of this information will be repeated today, so I'll spend less time on that, and so we can focus more on the mental health concerns. Overall, this is 2021 numbers from the CDC, estimated that over 32,000 new infections of HIV every year. This is an increase, a decrease from previous numbers. I remember doing this type of presentation at least once or twice a year, and the number for a really long time was 40,000 new infections per year. So while that number has decreased, obviously we do want to get that number down to zero, especially with the Getting to Zero campaign. With that in mind, our racial HIV disparities still remain. You can see here on this graph that of those 32,000 new infections per year, Black African American community members and Latinx community members still constitute a larger proportion of new infections. So when we think about the intersections of HIV status and access to services, and our BIPOC communities, our Black, Indigenous, persons of color communities, there's still disparities here that we really need to look at. There's disparities when we think about race and sexual identity as well. So this graph shows the darker orange that is on the top and the lighter orange that is more on the bottom here, shows the intersections of how gay and bisexual men are the communities that are still most affected by HIV. So obviously there are intersections of disparities that we still need to work on. The research needs to come to support the interventions that drive the community efforts that we're able to do this. When we look at the intersections of homelessness and trans persons living with HIV, we know that trans community members are at greater risk of experiencing homelessness in the past 12 months. So this graph shows that in this particular study, 8% of all people with HIV have experienced homelessness in the previous 12 months, whereas trans people with HIV, almost 30% of them have experienced homelessness in the prior 12 months. That's a staggering number. This one looks at HIV status and continuum of care. So the columns are divided into various age groups. On the far left, you have ages 13 to 24, and on the far right, you have 55 and older. And the continuum of care looks at this first row is, are they receiving their initial care for HIV? So this is, have they seen an HIV specialist? Have they seen their primary care provider that's treating their HIV? Have they been started on medications that potentially would be helpful? The second row is that of those, how many came back for another visit? So this is retention in care. This number is important because we could give them the initial medications and have that primary visit, but then what if they don't come back? Are we able to follow them up in ways that allow them to be able to get the care that they need? This third row here is that of those who have been retained in care, how many are virally suppressed? They may have the medications, they may have the health providers, but do they have the resources to be adherent to their medications? And we know with HIV, of course, a high adherence rate is needed in order to have a suppressed viral load. So you can see here that across these age groups, there are lots of opportunities for work here, whether getting more folks treated and into care, helping folks to stay in care, making sure that we have culturally competent providers to be able to provide the services to our folks, and then being able to provide resources, recognizing that many things impact adherence to medications, things like depression, anxiety, experiences of trauma, so on and so forth. So here today, I'm going to state a little bit of the obvious here with this slide, but we're talking about a conference that is dedicated to talking about mental health concerns among older adults with HIV. And the fact that we're talking about older adults with HIV doesn't escape me. And I know that this statement here is one that probably most of us know. Today, a person with HIV can expect to live a long, healthy life with emphasis on strong quality of life. I say this, and I have a slide just for this because this is so important. We're here to talk about how our HIV community is getting older. And that wasn't always the reality before. And I'll try not to get too emotional as I share a couple of stories. Earlier, Vince shared his story, and one of my managers who is retiring actually later this month, she has a similar story that she shared with me that continues to touch my heart. She was diagnosed with HIV 25 years ago and had 0 T cells. She was given 6 months to live. She told me that despite that diagnosis and prognosis, She never told family, she never told friends, she never once believed that she was not going to live to see the next year. Not only did she, but she is retiring after 25 years of service to an HIV service organization in San Francisco. And that retirement party is going to be the best retirement party ever, because just the fact that she is so resilient and came through so much. She talks about how the community that she chose, the community that she's in, is what allowed her to be there. Another story comes from my VA days. We annually celebrated World AIDS Day, December 1st. We had an veteran art showcase that we did every year, and one of the artists was a former client of mine who created this reliquary vessel. And one of the earliest studies in the US was called the VA Cooperative Study 298. And in this study, it was over 300 participants, 338 to be exact, who had T cells between 200 and 500, and many who had advanced disease. They were all started on the early trials of AZT. As many of us know, AZT had limited benefits and had a lot of controversial aspects to it. And the study also found that persons of color had even more limited benefits to AZT. Despite that, through the completion of the study, every person who participated in the study put their name in this reliquary vessel, and then they sealed the reliquary. And so every year during World AIDS Day, we bring this reliquary out to say that we still have work to do, because the promise that was made was that when there's a cure for HIV that's found, that's when we're going to open this reliquary, and we're going to honor in a symbolic gesture, recognizing that until that happens, we all have more work to do. So next, we'll talk about some common concerns related to aging. And so when you look at this list here, this is probably not a surprise, right? Because these are common concerns to aging regardless of whether of your HIV status. But then it can be more pronounced and compounded with HIV status and the comorbidities associated with that. So when we talk about pain, we talk about the impact of aging and influence of aging. We can talk about co-infections and comorbidities. Depression, we know that folks with depression who have HIV, actually depression can accelerate disease progression. And we know that folks with HIV may have higher prevalence rates of depression. We know that isolation can be an issue, less social and community integration. Of course, things like pill burden, recognizing that folks with HIV who are long-term survivors may have been through many iterations of their HIV medication regimen over the past 10, 20, 30 years, and that can be burdensome. I mentioned adherence to medications earlier, and for folks with HIV, adherence to medication oftentimes looks like 95% and higher, whereas with some other chronic concerns, good adherence we might think of as 80, 85%. So the importance here of taking medications every day. And then more pronounced sleep concerns. When we think about the intersections of common concerns, though, in terms of intersections of aging, HIV, and mental health status, mental health concerns, these are compounded by the impact of HIV and aging. So we'll go through each of these more in an individual slide. First one being HIV-related stigma, next one being loss of loved ones to HIV, experiences of PTSD and trauma. We know that folks with HIV who are long-term survivors have a greater prevalence and history of trauma of all sorts, including intergenerational trauma, experiences with PTSD, experiences that might have influenced how they became HIV positive, and so on and so forth. Cognitive concerns, and then signs of HIV and aging as our folks continue to age. So in the next few slides, you'll see that I start the slides with quotes. And this is what I mentioned earlier, where these are quotes from my own clients who I've worked with in the past 15, 20 years. This first one, I felt like no one wanted to touch me. This is talking about HIV stigma. So we talk about stigma quite a bit. And I can talk about stigma a lot because I know the impact of HIV stigma, especially when we think about layered stigma. Stigma was also my dissertation, so you would think that I would try to avoid this topic as much as possible, but here we are with that. Stigma was kind of first coined in the 60s by Goffman as an unfairly attached attribute that can spoil an identity. HIV is easily stigmatized due to its association with this sense of controllability, this sense that, oh, HIV status is because of a person's behaviors or choices. So this sense of controllability makes HIV even more easily stigmatized. And then, of course, we have to talk about the intersections of stigma. Earlier, we talked about HIV status. We can also compound that with someone who has veteran status, for example, or is a member of the LGBTQ plus community, as someone who is a person of color or a person who uses substances. So we can think of this as layered or multiplied layers of stigma that can impact a person. We know that stigma has a lot of significant impacts. There is ample research out there that talks about how HIV-related stigma specifically, independent of other types of stigma, can be associated with increased depression, increased suicidal ideation, increased anxiety, experiences with trauma, decreased self-esteem, less adherence to their medications, which could be life-saving. Folks with a lot of stigma may be less likely to disclose their status to partners and sexual partners. They may be more likely to miss their clinic appointments, and it goes back to that continuum of care. More missed appointments, less access to care, less likely to be virally suppressed, and also less perceived support. Next one is, who else is there to lose? The sense of grief, bereavement, and complicated bereavement, and survivor's guilt. Even though this study is a little bit older, in 2003, I reference this one quite a bit because I remember reading it for the first time and being so staggered by the compounded loss that folks experience. In this study of over 250 folks examining grief and loss among people with HIV, the average number of lost loved ones was 30. Imagine losing 30 of your loved ones in a short period of time. And these are folks coming from Milwaukee and New York. And the median in that group was 10. The fact that the median is 10 and the average is 30, that means that the range was staggering. That means that the range in terms of the folks that lost the most number of people were in the hundreds. So of these hundreds of folks that people lost to HIV or HIV-related concerns, about 40% were partners or spouses, about 20% were family members and caregivers. So not only losing loved ones, but losing loved ones who are your core family or core chosen people. Related to that is this quote, "Why not me?" or "I'm on borrowed time." So this sense of, why did I survive? How did I survive versus my partner? Or why did I survive and not my caregiver? Why did I survive and not my best friend? What were the things that allowed me to be able to make it to become a long-term survivor? So this sense of survivor's guilt. I facilitated an HIV support group for 12 years, and this came up constantly, this sense of why me, and I'm on borrowed time. Next, to not know what's happening to my mind is the worst part. We know that there is substantial evidence out there to support that there's neuropsychological or cognitive impairment, particularly in the later stages of HIV and AIDS. It's estimated that actually 30 to 50% of people with HIV experience what we call HIV-associated neurocognitive disorders, or HAND for short. And we know there's many contributing factors here. We can't forget, of course, that HIV itself impacts the central nervous system, so that independently is a factor. And then you have these other factors and influences here: low CD4 cell count, effects of aging, number of comorbid medical, psychiatric, and psychosocial concerns. Perhaps they've had experiences with homelessness, which then can impact their cognitive capacity, the impact of medications and their antiretrovirals, substance use, physical and emotional stress, and co-infections such as hepatitis C. This quote also sticks in my mind quite often as well. I'm thrice forgotten in Turlock. Turlock is a rural community nearby in Central California. So this person was referring to being forgotten for their HIV status, being forgotten because of living in a rural community, and being forgotten because of their trans identity. So while HIV prevalence rates may appear to be lower in some rural communities, access to effective and timely HIV care is often more challenging. Now, I put an asterisk next to the word appear because, interestingly, data for HIV persons are not collected where they live. It's collected where they receive care. So for folks living in rural communities, oftentimes what's happening is that they're not necessarily receiving their care in Turlock or the communities in which they live. They're driving to the cities, San Francisco, San Jose, Los Angeles. So it can seem like there are less folks living with HIV in rural communities than there actually are. Now, you can imagine the trickle-down effects of that, right? If we have data that says that more of our folks live in cities or in urban areas, where are our resources going? To our cities and urban areas. So who gets left behind are our folks living in our more rural communities. And then when we think about intersections again, the intersections of stigma, less access to service, even more physical isolation because of living in rural communities. Of course, we have an opioid epidemic happening in the US. And as I mentioned, our resources tend to be more heavily resourced in urban areas, which allows for more capacity building. So we really need to be able to find resources in our rural communities in ways that impact them as well. So before I go on to my next slide, I actually would invite the audience to close your eyes if you're willing. I'm going to read off some terms, and as I read these terms out loud, I want you to think about what comes to mind for you. So feel free to close your eyes. It'll be just about a minute. And you don't have to if you don't want to. So the first word is social distancing. Stigma, 6 feet apart, quarantine, isolation, losing loved ones, privilege, power, and access to care. Now open your eyes. What am I talking about? Okay, COVID. Is it COVID or is it HIV? Is it both? As discussed earlier, our folks with HIV, COVID was a re-triggering event for a lot of our HIV, especially our HIV elders. So this sense of it's happening all over again. And when we talk about intersections, we recognize that our folks living with HIV, because of the potential for a weakened immune system, would be more susceptible to the impact of COVID. So they were much more likely to have a harmful impact. And it triggered this reminder of what it was like for them to have HIV, and especially in the early days, be told, I'm not going to be near you, I'm not going to be associated with you, or I don't know how to care for you. Many folks in my HIV support group would talk about how COVID was a reminder to them of what it was like for them for so many years, to be forgotten, to be left, to be ignored, and to be isolated. And as mentioned before, the fact that HIV research was the catalyst for what we know in terms of how we found a vaccine for COVID, right? And as mentioned before as well, recognizing that there's still not a cure for HIV. So for our HIV community members, recognizing that the research, what if the research for HIV was accelerated as quick as it was for COVID? The intersections of that were not forgotten for us, and realization that there remains no cure. So what are some of our paths forward? I'm going to start more globally and systemically and talk about strategy, and then kind of move more inward and talk about healthcare, community, and relational aspects of paths forward, and then end with kind of more self and individual paths that we can look at. First is the Getting to Zero strategy, which many folks may be familiar with. This was put on by the strategy by the Joint UN Program on HIV and AIDS in 2011-2015. This is a strategy that tries to emphasize HIV prevention and strategic partnerships to advance HIV care, ensuring things like better treatment, better access to medications, better national programs to address the needs of our minoritized communities, including our LGBTQ+ community. And so the strategy here is the zero new infections, zero HIV-related deaths, and zero HIV stigma and discrimination. So while this was a global strategy, you can see here that many different places have had their own versions that are implemented locally. And this is where we can have that local impact from a global strategy. You can see the ones for San Francisco, Getting to Zero Illinois, Getting to Zero Connecticut. And then to kind of move us into the US, was already mentioned earlier, ending the epidemic, so I won't spend too much time on that. We have 4 pillars here: to diagnose early, treat effectively, use proven tools such as PrEP, use proven tools such as evidence-based treatments, and respond thoughtfully, recognizing that for us in the US, the goal here is to reduce new HIV infections by 75% by 2025, and by 90% in 2030. And then we can move more locally. So this is a model that is instituted in San Francisco, just to kind of share a little bit of a local model where my agency is located. This is using community health models to enhance access and care. So what the San Francisco Department of Public Health did is really look at what were our communities who were most at risk. And how would they benefit from being able to get care from peer navigators and peer providers? So identify these 7 communities of focus. For example, Asian and Pacific Islander communities, Black African American, gay, bisexual, men who have sex with men, Latina, Latine, Latino, Latinx, people who use substances, and people who experience homelessness, trans women of color, and young adults. So this model is the example of this model would be where trans women of color who were providers, case managers, peer navigators, social workers were providing services and outreaching to other trans women of color. So this model helps to use global data and national data in ways that are impactful. My agency is part of several of these communities of focus, and so having our staff who identify in these communities has been instrumental in making sure that we're outreaching in a way that is culturally comprehensive. And then I'm kind of narrowing in now on healthcare. If folks saw the Netflix special, Living in the Blue Zones, this probably is a little bit familiar to you, but we really need to increase our emphasis on caring for our older HIV community members, our HIV elders. So that means increasing access to care. Our folks need access to geriatric specialists and gerontologists and geropsychologists. Knowing that our folks are older and are aging gracefully, we need to be able to have folks who care for them who have these geriatric competencies. We also need to emphasize movement, and it doesn't need to be running marathons and running ultras. These are things that are natural movements. So exercise, hobbies, recreation, of course, emphasizing health, access to healthy food, access to mental health, access to therapists, and then of course, connection, remembering that isolation and stigma remain with us today. So peer support, warm lines, helping to connect our members of our community to their chosen tribes. This is a model of integrated care. This is referring to healthcare again. This is the model that we used in the clinic that I worked in for 12 years, where the client is in the center of their care. And notice that surrounding them are all these different specialty providers. Access to primary care, their administrative team, having a drop-in clinic, having immediate access to a social worker or case manager, and therapy. And then on the right here is every single service that my clinic provided when it comes to mental health care alone. So it wasn't just individual therapy. It was individual therapy, it was groups. And these groups were based on what was needed, not just what was needed based on the evidence, but what our folks told us they needed. They said they needed a group for depression, so we did that. They needed a group for enhancing their memory, so we did that. Having opportunities for assessment, joint visits. I love joint visits, helping our medical providers see the benefit of integrating medical, mental health, and social work care in the same visit so that the client and the patient can feel like all of these needs are being addressed simultaneously. We also need to compassionately reach folks in rural communities. And so in order to do this, we have to emphasize telehealth care. And telehealth care has to be adaptable. I know that we're increasingly in hybrid workforces, and these can be hard, these can be complex, but we have to adapt to telehealth care in ways that are accessible to our folks. This might mean sending our folks iPads or making sure that they have Wi-Fi connection, making sure that we build clinics that are accessible for them in their own communities. We also have to enhance HIV and elder care competencies, including peer provider education. And again, as mentioned earlier, we have to focus on capacity building, recognizing that our rural communities are not necessarily getting the resources. As a result, they're not able to build capacity to care for our HIV elders the same way that our urban and cities are able to. So that brings us to our 4 A's. I'm big on alliteration, so I apologize for the cheesiness. The first one is to ask. Ask our elders with HIV about their stories. Let them guide us. Don't make assumptions about what they need. So many times in meetings, we would really harp on what is it that this person might need. Based on my experiences, I think that they need this. Oh, I think they need more mental health. Oh, I think they need more case management. We have to ask our elders what they need. And whenever they tell us, we have to listen. We have to avoid generalizations. We have to share their stories of love, pride, courage, and resilience. As much as we're talking about these concerns that they may experience, we have to remember to celebrate them. We have to assess for concerns, the common, the pain, the sleep disturbance, the depression, but also the covert, the brain health concerns, the issues with stigma. Next is to acknowledge. We have to validate their lived experiences, recognizing that their lived experiences, past and present, are valid, are true, and are part of what have made them who they are. We have to affirm that intersectional impacts of stigma, impact of racism, impact of transphobia, impact of misogyny, all of these have an impact on our folks. We have to honor their journey that they took to get here, and we have to commit to using affirming and non-stigmatizing language. I have a lot here for advocacy. I recognize advocacy is near and dear to my heart, so I have a lot of different examples here. Learning about HIV care, learning about what your communities need, sharing this information with others. I'm from Oklahoma, so I try to share this information all the time, recognizing that we don't necessarily have the same access to resources that we might have in California. Being an ally, when you observe HIV stigma being enacted, really standing up and being an upstander, being an ally in that situation. Writing your local officials, organizing a discussion with stakeholders of your agency on how to better meet the needs of the HIV elder community. Inviting the elder community into those discussions. Forming interdisciplinary committees, getting loud at days of action. There's plenty of those throughout the state of California. Joining HIV planning councils and awareness campaigns. Partnering with schools, clinics, and service organizations. The number of schools and institutions that have come to our agency to say, we don't know how to start this discussion. Can you help us? So really the benefit of integration and partnership. And then plan celebrations and opportunities to be in community. Last is to amplify. As we've been mentioning all along, amplify their stories, amplify their journey, amplify their healing, celebrate, play, be proud, be prideful. These are the things that we've been working for that have gotten us here. So I'll end with what will be your singular, not singular, intersectional story about older folks and elders with HIV. Not only will they be, how will they be maintained, and how might your other narratives better serve our community? And I'll end you with how will you advocate for and be a part of a system of influence in building and maintaining community for our older adults with HIV. Thank you.